next speaker is Dr. Shruti BISEN, who will talk on retinal hemorrhages with neonatal polycythemia and thrombocytopenia.
Good afternoon, everyone. I'm Dr. Shruti BISEN. My topic for today is retinal hemorrhages with neonatal polycythemia and thrombocytopenia. Retinal hemorrhages in neonates refers to the occurrence of bleed within the retina in a newborn's eye. This happens when tiny blood vessels in the retina break, causing the blood to leak into the surrounding retina. Neonatal polycythemia is defined as an hematocrit or hemoglobin levels above the upper limit of the normal, that is more than 2 standard deviation for gestational and postnatal age. That is, hematocrit values for peripheral venous sample is more than 65% and hemoglobin more than 22 grams per deciliter. Neonatal thrombocytopenia is defined as platelet count less than 1.5 lakhs per microliter. Neonatal polycythemia affects 1 to 5% of newborns in the general population and 22 to 35% in those are admitted in NICU. Neonatal thrombocytopenia occurs in approximately 51% of the patient with polycythemia. The pathophysiology behind thrombocytopenia includes, with polycythemia, often involves a combination of factors such as decreased platelet consumption, altered platelet function, or reduced production. Increased hematocrit lead to decrease in the platelet count, which may be responsible for retinal hemorrhages. However, the risk of retinal hemorrhages due to untreated thrombocytopenia should be carefully considered. My case presentation was the preterm child, a female child born by normal vaginal delivery at 32 plus 3 weeks of gestational age with low birth weight of around 1100 grams to a primigravida mother with a severe preeclampsia was just admitted to NICU. On the first day of life, baby has developed a respiratory distress for which the baby has received an oxygen therapy with the nasal prongs for 7 days of life. Routine blood investigations were said, complete blood count and peripheral smear. The CBC report indicates thrombocytopenia with polycythemia with hematocrit levels of 70% and a hemoglobin value of 25.3 grams per deciliter and a platelet count of 57,000 per microliter of blood. The treatment for polycythemia and thrombocytopenia was given in the form of partial exchange transfusion followed by platelet transfusion with random donor platelet concentrate. Baby was screened for any ocular abnormalities, but torchlight examination and reveals no external ocular abnormality seen. Buckner's test was performed with direct ophthalmoscope for each eye and bright red reflex was seen. Pupils were dilated using dilating drops containing 0.8% of tropicamide and 2.5% phenylephrine hydrochloride, single drop in each eye instilled into conjunctival sac at the interval of 15 minutes, at least twice or till 6 mm pupil is dilated. Dilated fundus examination was performed at 3 weeks of life, which includes postmenstrual age of 35 plus 3 weeks, and found that multiple retinal hemorrhages were seen in both the eyes, and no evidence of retinopathy or prematurity was seen in both the eyes. The baby was examined twice weekly, 2 weeks, and multiple retinal hemorrhages were observed, which begins to resolve spontaneously by 5th week of life and resolve completely at 7th week of life. The postmenstrual age is 39 plus 3 weeks and baby was followed up till postmenstrual age of 40 weeks. Here are the pictures representing during the first screening, which was 35 weeks. The retinal hemorrhages were seen in both the eyes. At second screening, there were resolving retinal hemorrhages, and at third screening, we found that none of the retinal hemorrhages persisted. This case report describes an occurrence of retinal hemorrhages in neonate with polycythemia and thrombocytopenia. Retinal hemorrhages in neonates are often linked with factors such as birth trauma, hypoxia, polycythemia, or thrombocytopenia. In this case, polycythemia is likely to play a key role in development of hemorrhages as increased blood viscosity, impaired microcirculation, and thrombocytopenia further compromise the infant's ability to clot, increasing the risk of retinal hemorrhages. These tables indicate that as the progressively we goes on screening babies, hematocrit values are going down, hemoglobin levels are also going down, and platelet counts are increasing. In parallel with these hematological changes, there were resolution of retinal hemorrhages initially observed in early stages of life. During postmenstrual age of 35 plus 3 weeks, retinal hemorrhage progressively improved with complete clearing at 39 plus 3. increasing platelet count and decreasing hematocrit and hemoglobin levels likely to contribute to healing process of these hemorrhages, demonstrating the positive impact of improved platelet level in resolution of retinal damage. This case underscores the dynamic nature of hematological and clinical recovery in preterm infants with observed changes in blood parameters correlating with the resolution of retinal hemorrhages. To conclude, neonatal polycythemia is highly prevalent in infants associated with low birth weight and maternal pathologies like diabetes mellitus and preeclampsia. These risk factors impact both incidence and severity of presentation. Polycythemia and thrombocytopenia are responsible for retinal hemorrhages, which may lead to vitreous hemorrhages at times. Prevention and treatment of this condition should be warranted earlier. Thank you.
Thank you, Shruti. Any questions?
So the cause of retinal hemorrhages, what is the most likely cause? Is this the hematocrit increase or is it the drop in platelets?
So, in my case, both the conditions were coexisting. But
in
many of
literature-
the research paper, what I have read, that includes the polycythemia was the main cause for retinal hemorrhages.
Okay. Thank you.
Thank you, sir.